This presentation is entitled Echocardiography for Emergency Physicians, a bit beyond basic. As many of us will know, there are considered four basic views in echocardiography. The first one is the parasternal long axis. The second one is the parasternal short axis. The third one is the apical four-chamber. There are additional apical views. And then the fourth one is the subxiphoid view. Regarding the first two views, they're both taken in the same area, which is just to the left of the sternal angle. So that's the parasternal long and the parasternal short views. The apical views are taken in point C on this diagram, which is where the apex of the heart is, and the subxiphoid view is taken in the subxiphoid space. Parasternal long axis is taken with the cardiac probe pointed towards the right shoulder, and you see, as you can see in this schematic diagram, mostly the left ventricle, part of the right ventricle, the left ventricular outflow tract, the left atrium, and the mitral and the aortic valves. And you tend not to see the apex of the heart. The parasternal short axis is taken with the probe, following the probe being rotated 90 degrees towards the left shoulder, and you get a cross-section of the heart through the left ventricular wall and also through the right ventricle. The apical view is taken at the apex of the heart, and you see all four chambers of the heart. That's called the apical four-chamber. There is an apical five-chamber, apical three-chamber, and an apical two-chamber. And these images are formed by rotating the probe in various directions. And the fourth main view is a subxiphoid view taken with the probe in the subxiphoid space with the marker towards the patient's left. And you see again all four chambers of the heart. The probe can be rotated 90 degrees in an anti-clockwise direction, and you get a similar image to the apical parasternal short axis view. You can also make an assessment of the IVC in this orientation. So returning to the start of our examination, which is the parasternal long axis, and usually after eyeballing cardiac function, we try to make an assessment of the left ventricular function. And there are four assessments that we try and make. One is through looking at the function of the myocardium, whether the myocardium thickens and shortens in systole. There is a measurement called E-point septal separation, which we'll go through. Another measurement is fractional shortening between systole and diastole of the left ventricle. And then the fourth measurement that we'll talk about is mitral annular systolic planar excursion, or MAPSE, which indicates the left ventricular longitudinal contraction. That's actually taken in the apical four-chamber view. So initially we look around the left ventricle, put colour through the mitral valve and the aortic valve, looking for eccentric jets indicating mitral or aortic regurgitation. And then we go for our measurements, which is initially the M-mode cursor through the tip of the mitral valve, looking for the E-point septal separation. There are two short clips of colour through the mitral valve. The second one which showed a very trivial amount of mitral regurgitation. So E-point septal separation, or EPSS, shows the distance between the mitral valve when it's fully open and the intraventricular septum. So if the tip of the mitral valve touches the septum, correlates with an ejection fraction of approximately 60%, or a normal ejection fraction. If it reaches halfway towards the interventricular septum, approximately half normal left ventricular ejection fraction, or about 30%, and then if it's less than that, then ejection fraction is approximately less than 30%. There's a formula there if you want to calculate left ventricular ejection fraction based on the E-point septal separation. So you can see in this image that the M-mode cursor is through the tip of the mitral valve, and you can also see in a patient in sinus rhythm, there is an E wave and an A wave, which is reflected in movements of the mitral valve. So we measure the point between the tip of this E inflection and the septum. And 7 millimeters is considered normal, or less than 7 millimeters is considered normal to correlate with normal left ventricular function. Following that, we measure the fractional shortening, so moving the M mode towards the apex beyond the tip of the mitral valve, and measuring the change of the size of the left ventricle between systole and diastole. And fractional shortening is 25 to 45% is considered normal. And an approximation for the left ventricular ejection fraction is 2 times fractional shortening. After that, the next measurement we take is of the left ventricular outflow tract, which is the area where the aortic valve inserts into the left ventricular outflow tract with the aortic valve's leaflets fully open. We measure that diameter, and that's useful for future calculations. And you can see it in that image there. After that, you can measure the left atrial diameter. You can also measure the diameter of the aorta itself, the proximal aorta. Additional images in the parasternal long axis view, you can angle cranially, you get a view of the pulmonary valve. You can also angle caudally, you can get an image of the tricuspid valve. They're not standard views, but they can be useful. Following the parasternal long axis view, we rotate in a clockwise direction with the marker of the probe pointing towards the patient's left shoulder, and we get the parasternal short axis view, which is a cross section through the left ventricle and right ventricle. And there are various levels, so we look at the aortic valve level through the mitral valve papillary muscles and angle down towards the apex. You can also angle towards the patient's left shoulder to get a view of the pulmonary valve, and then towards the right hip, so downwards, to get a view of the tricuspid valve. And it's usual to put colour Doppler through the aortic and mitral valves to see if there's any evidence of regurgitation. So there's a short clip of parasternal short axis image. That's at the level of the papillary muscles. And just putting colour through the aortic valve. And also through the mitral valve. There's a tiniest bit of mitral regurgitation that you can see in that image. One can also measure fractional shortening in the parasternal short axis rather than the parasternal long axis. It's very similar to what we did in the long axis. So M-mode cursor through the left ventricle and taking measurements in systole and diastole. One can also measure the aortic valve area in the parasternal short axis view using planimetry, or we can calculate it using velocities in the apical 4-5 chamber view, which we shall do later on. The next view is the apical 4 chamber, taken with the probe at the apex of the heart, with a marker towards the patient's left, and we see all 4 chambers of the heart. We can measure the ejection fraction using Simpson's method in left ventricular end diastole and end systole. You can also measure the same in an apical 2 chamber view, which adds to the accuracy. An additional measurement of left ventricular function is called the MAPC, which stands for mitral annulus planar systolic excursion, and that measures the longitudinal movement of the mitral annulus during ventricular systole. It's measured using placing an M-mode cursor through the lateral part of the mitral annulus. And there are measurements for normal. Greater than 13 millimeters in a male is normal, or greater than 11 millimeters in a female. And also you can estimate the left ventricular ejection fraction, which roughly equates to 5 times the MAPSI value. So this is how the MAPSI is measured. Moving on from that is to estimate the function of the right ventricle. In a similar fashion, there is a TAPSI, which is a tricuspid annulus planar systolic excursion, as a measure of right ventricular contractility, and normal is 16 millimeters or greater. One can also measure the right ventricular fractional area change, where you outline the right ventricle in systole and diastole and work out what the change in area is, and normal is greater than 35 millimeters. So this is a slide of TAPSI being measured. Following on those measurements, we look at the mitral and tricuspid valve morphology and then put colour through those valves, looking for regurgitation or possibly stenosis. And you can also put continuous wave Doppler through the valves, looking for evidence of a small amount of regurgitation. And you'll see flow in the opposite direction, i.e. regurgitating through the valve. So this is a clip of mitral regurgitation, and then the following clip is of tricuspid regurgitation, which looks like moderate severity. The next measurement that one can perform is a pulse wave Doppler through the mitral valve, giving the E and A values. As we said before, the mitral valve signal has E and A waves in it. And there are tables of normal, and this is part of the assessment of ventricular compliance or so-called diastolic dysfunction. Right. The next thing is to assess pulmonary artery pressure, which sounds complicated but isn't really. So from an apical 4-chamber view, you can use the tricuspid regurgitation signal, which most people have, even a normal people, majority of people have a degree of trivial tricuspid regurgitation. Using continuous wave Doppler through the tricuspid valve, you measure the peak velocity of regurgitation, and then that can estimate the pressure differential between the right ventricle and the right atrium using the modified Bernoulli equation. So the pressure gradient equals 4 times the square of that peak velocity. So that will give you an estimate of the pressure differential between the right ventricle and the right atrium. If you add on the right atrial pressure, which you can estimate from the size of the IVC, you'll get the pressure in the right ventricle. And then the pulmonary artery pressure, systolic pressure, is considered continuous to the right ventricle, pressure in the right ventricle. So there's the same value in most cases. So continuous wave Doppler through the tricuspid valve, measuring the peak velocity of the tricuspid regurgitant signal, and then calculating pressure differential using the modified Bernoulli equation, 4 times the square of the velocity, and adding on our estimated right atrial pressure, which you get from the IVC in the sub-xiphoid view, and then that'll give us what the pulmonary artery pressure is. So less than 40 millimeters of mercury is normal, 40 to 50 is mild pulmonary hypertension, 50 to 60 moderate, and greater than 60 is considered severe pulmonary hypertension. Following that, in the apical 5-chamber, which you lower the tail of the probe, i.e. you angle upwards, and you'll see the left ventricular outflow tract as well as the aortic valve, and you can measure the velocities through the aortic valve and also in the left ventricular outflow tract, and from that you can calculate stroke volume, cardiac output, as well as the aortic valve area. So this slide is illustrating measuring velocities using pulse wave Doppler through the left ventricular outflow tract, and then the following one using continuous Doppler through the aortic valve. One can also put colour Doppler in the pulmonary vein. If someone has mitral regurgitation, you might see a regurgitation of blood into the pulmonary veins, which is one of the markers of a severe mitral regurgitation. So the final view of the main windows for echocardiography is the subxiphoid view, where the probe is placed in the subxiphoid space with the marker to the left of the patient. And here you get a good overall assessment of cardiac function. You can assess for pericardial effusions as well as just sort of overall ventricular function. From there you can rotate the probe in an anti-clockwise direction with the marker pointed essentially upwards, and if you angle towards the right, you'll get an assessment of the IVC coming to the right atrium. So here's an image with the probe pointed upwards looking at the patient's IVC, which in this case is fairly flat. And there are tables that correlate CVP with the IVC size and its collapsibility. Some debate about these, but they're useful, I think, to know. An additional view is the suprasternal view, which is, can be useful to visualize the aortic arch, and also you see the right main pulmonary artery. So the probe's placed in the suprasternal notch with the marker pointed upwards, cephalad, and you see the arch as well as below the arch is the right main pulmonary artery. So you may see a flap in a dissection, for example. And that is, I think, what I would consider to be a reasonable bedside echo for a critical care or an emergency physician, which is a bit beyond the eyeball and basic method that we're kind of being taught to do generally. Following on, there are just a few examples to look at and see if you can diagnose what the pathology may be.